COVID-19 in children, the diagnosis and home management, because we generally, we need only home management as far as children are concerned. I'll be briefly going to the clinical features, which all of us are familiar with, the investigations, the home management, the red flag signs, and the primitive aspects. The clinical features, all of it, as I said, you are all familiar with, but I'd like to highlight the GI manifestations. Abdominal pain, loose stools, and occasional vomiting. This is more in children. And there's less of loss of smell and taste. People say the loss of smell and taste is almost sure that the patient has got COVID-19. But in children, especially children less than 8, it is not there at all. And then more than 8 and 12, even the incidence is much less. Probably they're not able to appreciate it, and probably they're not able to report that. So when do you suspect COVID-19 in a child? Fever, headache, myalgia, fatigue, tiredness, coryza, cough, sore throat, rapid breathing. You all know these are features of an upper respiratory infection. Or as I mentioned, diarrhea, vomiting, abdominal pain. This again is significant, especially in this way. Or poor feeding in an infant, loss of taste or smell, as I mentioned, more than 8 years. Or rash, congenital congestion, mucositis, and shock, especially that indicates a multi-system involvement. And if a close household contact there's a contact with the COVID-19 case, then also you have to suspect, because 50 to 60% of children are asymptomatic in this way when compared to only 20 to 30% in the adults. So if you have any of these things, especially in this COVID pandemic, it's always better to be on the safer side and get them tested. Now, when do you test? The definite indications are history of contact, as I mentioned, but now we are saying that it may be deferred if the child is asymptomatic, because if the whole family is symptomatic, we take it that the child is also symptomatic, because it may be difficult to get the COVID testing done on a child, and there may be other factors also. So ideally, the history of contact, you should do it. But if the child is asymptomatic, you may defer it, not that you should, you may defer it. Any influenza-like illness during this pandemic, a severe acute respiratory infection, and suspected MIS-C. Other indications which you mandatory do are before any procedure, because we don't want them to pass on the infection to somebody else, and before hospitalization. We have 3 categories. Again, you're all aware of it. I'll just run through them. You have mild sore throat, cough and rhinitis, upper respiratory infection, and diarrhea. They've come into category A. In addition to that, if you have fever and if these symptoms aggravate, like severe sore throat, cough, then it comes to category B. Or if category A with risk factors like a cardiac problem, your nephritis, nephrotic syndrome, or hepatic problem, or any of those things. Also a category A with children who are on long-term steroids. If any of this is there, we bring it into category B. And category C, we have breathlessness, chest pain, drowsiness, hemoptysis, hypertension, cyanosis, all those things where this slightly higher. So we have category A, B, and C. Now, as far as the clinical severity is concerned, we classify mild, moderate, and severe. Mild is category A and B. They don't have hypoxia or breathlessness. So category A and B together form mild one if there is no hypoxia or breathlessness. Now, category C comes into both moderate and severe. In moderate category C, you have a tachypnea depending on the age. As I mentioned, as you all know, more than 1 to 5 years is more than 40 per minute. That's less than 2 months is 60 per minute. While the SpO2 is between 90 and 94. There's a 94 is the cutoff point, which I mentioned. So if it is less than 94, but above 90, we classify it as moderate. And then a severe variety, there are danger signs, inability to feed, grinding, lower chest indrawing, altered sensorium, seizures, etc. And in these cases, the SpO2 will be less than 90. So we have category A, B, C, and the clinical severity we classify it as mild, moderate, and severe. Now, confirmation of the diagnosis is the most important aspect. Is it COVID-19 or not? We have the molecular diagnosis, the antigen detection, the antibody detection, the lab test, and the radiology. I'll be going through some of them in detail. So the molecular diagnosis is a nucleic acid amplification test, NAT, which is commonly known as, is taken from the respiratory secretion and is the gold standard. And one of the most common NAT is RT-PCR, which you're all familiar with. RT-PCR tests are highly specific, but they detect only RNA sequence of the virus, so they can remain positive for weeks and months. Earlier, the pattern was to test the RT-PCR after 2 weeks, and if this is still positive, keep on doing it till it is negative. But that is not required, because if the RNA sequence of the virus is there, it will remain positive, whether the child may not be infectious and the disease might have already subsided by the time. And the sensitivity of the kits also vary depending on the target genes that you're using. So it's a semi-quantitative test, and a few things about the cycle threshold, which is usually quoted in RT-PCR tests. So they have a threshold we take in a hospital, 35 as a cutoff point, and some institutions take 40 as a cutoff point. So a low CT value means there's a high viral load, because CT means the number of cycles that need to be run to amplify the RNA. If with the less number of cycles you're able to amplify the RNA, that means the viral load is very high. But you need more cycles to amplify the RNA, that means the viral load is less, or they are non-viable virus and low risk of transmission. So what we do is, if it is less than 35, we classify it as positive. If it is more than 35, we either say it's a negative or equivocal or non-viable virus. TrueNat testing is something which is an easier one. It's a chip-based RT-PCR machine. It was initially used to diagnose tuberculosis, but we found that it could be used for COVID-19 also. The results are faster, and it enables the same-day testing and reporting. Now, the rapid antigen test, it is becoming in the papers, all these, the government has advocated RAT instead of RT-PCR. It is again done from the nasopharyngeal swab. It's a point of care test, and the turnaround time is 15 minutes. But then 15 minutes from the time the sample is being taken and collected, and the test is being done. So the test should be done within 1 hour of sample collection. That's a naked eye evaluation, 15 to 30 minutes. It's very specific. That's a good thing about it. It's 99.9% specific, but it has low sensitivity. Because it has low sensitivity, a negative test needs to be evaluated by RT-PCR. If it's a positive test, then it shows it's a COVID-19. But if the test is negative, then we cannot be sure that there's no COVID-19 infection. So it has to be evaluated by an RT-PCR if required. Now, there are new self-test kits in the market. Last 2-3 days, it has become in all the papers. That is a test approved by ICMR. It's a home testing of rapid antigen. Kits are available in the medical store. It'll be shortly available. What I understand is the medical stores have not yet got it. Maybe in another 2-3 days' time, this will be available in the medical store. The cost is roughly about, I think, 250 rupees. You buy the kit, and then the mobile app available. You download the app on your mobile phone, and then do the test. It's very simple. They're giving all the sequences of how you should do it. It can be done at home. Then take a picture of the test strip after the procedure and upload it. It's centrally captured in a secure server, and then it's connected to the ICMR COVID-19 testing portal. So patient confidentiality is maintained. And very simple, you can do it at your home, especially if there is a doubt. But this again is not very specific. So an RT-PCR should be done for symptomatic individuals who test negative. If you find that the patient is symptomatic and you're strongly suspecting COVID-19 and the test is negative, you have to do an RT-PCR to confirm it. Now, this is a test. The government has approved this. COVID Self is a brand name now. Again, 3 or 4 other companies are getting their approval, which will be coming shortly into the market. Lab tests. We all do all these lab tests, but they are not routinely recommended, especially children, because the lab test may be normal in mild cases, or the child is otherwise normal. The lab test may be high because a lab test will really show that the inflammatory condition is there. There are changes in the hematological and biochemical parameters, but if the case is severe, the test will definitely be there. So a mild case, you do a test, and then you have a high value, you're confused. What should I do? Or if the values are normal, then again, you're confused. So routinely in the case of mild COVID, we don't recommend a lab test. In severe diseases, we have lymphopenia, raised neutrophils to lymphocyte ratio, the N/L ratio, supposed to be 4.5 in adults, but that is not applicable in children because in children less than 5 years, the lymphocytes are already high. So it should be a lesser number. But then this is taken as a value in adults. Low platelets or raised CRP. When you say raised CRP, it should be fairly high, more than 60 also is considered positive for COVID. If it's less than 60, probably it could be COVID, provided the other parameters are there. Elevated liver enzymes there because of multi-system involvement. Elevated D-dimer, ferritin, CPK, LDH, and interleukin-6. This can be done where required. If you want to know there are other manifestation, bleeding manifestation, thrombosis, and things like that. And procalcitonin is done routinely in some places, but the raised level indicates just a bacterial infection. It does not indicate COVID. But then if you're suspecting superficial bacterial infection, then definitely you can do a procalcitonin, but they're all expensive tests. I would just go in for a CBC and then a CRP, or the others only if required. Radiology, the X-rays are normally in mild and early cases. So here again, I would feel that they are not indicated. In severe diseases, you have bilateral infiltrates, sometimes complete whiteout on the X-rays. A CT is more sensitive than the X-ray, but it should not be used in children unless you're suspecting a very high chance of COVID when all the other tests are negative, or you are looking for other complications that could be there when the child is not improving in spite of your treatment, whether there are other things that are contributing to that. So other than that, don't do a CT. A CT, one CT thorax CT is supposed to be equivalent to 300 X-rays. So never go in for a CT unless it is absolutely indicated. So you find the less predominant involvement of lower lobes, more than the upper lobes, and more peripheral than central. The common radiological findings will be ground glass opacity, consolidations, crazy pattern, halo and reverse halo signs. Now this is a CT, you get a bilateral infiltrates, and then you have a predominant lower lobes involved compared to the upper lobes. And this is CT chest, the crazy impairment. The pediatricians are all familiar with the crazy impairment, and here you can see a typical crazy impairment here, and then the halo and the reverse. It's actually a reverse halo here, which is again is a pathognomonic of COVID. Now, well, we have been running around like the honeybee looking for honey. We have been running around to get proper tests done and proper therapy find out, because whatever we are saying is a living module. It keeps on changing every day. So let's hope, like the bee, we come and hit the right things and we can able to do something better for the child. Now, home management, paracetamol. This is the drug that has to be taken if there is fever. 10 to 15 milligram per kg per dose, as we are all aware, every 4 to 6 hours. Cough, maybe I'm finding nothing need to be given, just soothing agents, a warm saline gargle if it's an older child, or steam inhalation again in older child and adolescents, because you're giving a steam inhalation to a younger child, the chances are that the hot water will fall on the child and then you'll have to deal with the scalds also. So only in older children, we advocate steam inhalations. Fluid and feeds, normal food, and maintain hydration. That is something which you should stress to the mother. Give plenty of oral fluids and a good nutritious diet. Hello. The child is using nebulizations, tell them not to do it and avoid nebulization. Instead of that, you can use an meter dose inhalers and spacer if they are required. Even otherwise, if you feel that the bronchospasm, or in some cases you want to start on budesonide, go in for an MDI rather than a nebulization, because more of aerosol generation is there with nebulization. Now, continue medicines which the child is already on. This is something which you should stress. Okay, you them all, but if the child is already on some other medicine, maybe for a problem, maybe for a hepatic problem, or for a renal problem, ask them not to stop it, but to continue the same. The same time, if there is a doubt, ask them to contact the doctor who has prescribed the medicines and tell him or her that the child has COVID, and then modify only according. So I stress this point that the child should not stop any medicine which is already on. Antibiotics not indicated. We had various antibiotics that are including azithromycin and a lot of other things, doxycycline, but antibiotics are not indicated. We have enough and more studies to show that antibiotics do not modify the disease. You can give antibiotics if there's a secondary bacterial infection. and never self-prescribe. This is seen because the elder sibling has got a COVID-19 and the doctor prescribes some medicine. And when the younger child gets the same thing, they automatically buy the same medicine, give it to the child. So tell them don't self-prescribe because the intensity of the condition, the category may be different. So ask them to get a medical opinion before self-prescribing. And as I said, there's no role of hydroxychloroquine, ivermectin, antivirals, immunomodulators, and even convalescent plasma infusion. That was the big thing in the earlier part last year. But all those things, it is now reliably known that there are no role of any of those things. Vitamins and minerals. Well, it has been noted that vitamins are not effective in preventing the disease, neither will it affect the COVID or shorten the disease. But many of your children are deficient in vitamins and minerals, iron, vitamin D, all those things. So there's no harm in prescribing. And if they are taking vitamins, ask them to continue that. But tell them specifically, these are only going to help you. These are not going to help you as far as COVID-19 are concerned, but absolutely no harm. And monitoring at home, explain to the parent or caretaker that they should basically look at the respiratory rate. Check the respiratory 2 or 3 times a day when the child is not crying. The child is crying, of course, the rate will be high. So check it 2 or 3 times and note it down. Look for chest indrawing, a bluish discoloration of the body. They're very easy for them to know. How is the intake output? We chart it and find out how the child is taking intake, the oral intake and the output. Tiredness, poor feeding, altered sensorium, all these things are, they have to monitor it and get to the doctor if required. And oxygen saturation monitoring, now almost everybody has it as a handheld pulse oximeter. 100 is supposed to be the normal value. If it is less than 94, of course, they should contact a doctor. But in cases in children who have a cardiac disease or a cyanotic cardiac disease where the basal oxygen saturation is only about 97 or 98, then you don't have to jump into it just because it's less than 94. Because what is said is about 3 to 5% less than the resting value. So even if it is 93 or 92, there's no need to panic, but of course you can contact the doctor. So from the resting oxygen saturation, if it goes below 5%, then it is of concern. So in such cases, it's all you can contact the doctor, ask for the doctor, or even get an opinion through a video consultation. Why I mentioned about video consultation is it's easy for the doctor to see the status of the child, to see if the child is listless, is the child active, is the child looking hydrated, is the child lethargic. All those things can be seen by the doctor. So a video consultation, thanks to the IT, we do have very good video consultation almost all over the country, and anywhere in Kerala, you can have a video consultation both by the government and private institutions. The red flag signs, as I mentioned, breathlessness, decreased SpO2, as I mentioned, decreased urine output, nasal flaring, cold extremities, poor feeding, altered sensorium, excessive fatigability, syncope. So you tell them, tell the parents that if you find any of those things, or even if you suspect any of these things, contact the doctor, don't keep the child at home. A word about the 2-DG, this has come in the papers in the last 1 week, the miracle medicine. 2-DG is 2-deoxy-D-glucose. It was developed by the DRDO, that is the Defense Research and Development Organization. That is oxygen from the second position, glucose is removed. So 2-deoxy and from D-glucose, and thus you get 2-DG. What is seen is that it selectively accumulates in infected cells and cuts off the energy supply to the virus. So the infected cells get an accumulation of 2-DG, and so the virus is not given the energy supplies, the virus is cut off, and so the virus dies. So what they found out is effective in this. The virus cannot multiply, thus reducing the infection and the viral load. Now the significance of this is it increases the rate of recovery by reducing duration of symptom, dependence on oxygen is reduced. Now 2-DG has been used earlier for other conditions like hypoglycemia in children, and even a different variety, 18-fluoro-deoxyglucose, that is 18-FDG, was used in diagnostics to find out in malignancies, to find out where they, because these glucose accumulates in the infected cells or where they get turnover. So this is not very new, but then this is new as far as COVID-19 is concerned. And then it is available as sachet. Now, I don't know if it has been, a trial has been done in children, to what extent it can be done, but hopefully it may not create any side effects. So 2DG is now getting popular as the co-management of COVID-19. Now coming to the last slide, the prevention. How do you prevent this? Transmission is mainly through large droplets, and less by droplet nuclei and fomites, as was earlier believed. Now, especially fomites is very important in children, because it was believed that if the children touch somewhere and then you touch your face, that gets infected. But now it is known that even though fomites do transmit the disease, the chances are less in a child. So prevention still rests on the three basic principles of SMS, social distancing, and for a child, social distancing means stay at home, nothing more than that. Don't let the child go out. There's no need for the child to go out. Use of mask. Now, when I talk of mask, the WHO has mentioned that masks are recommended only for children above 12 years, because it may not be safer to use mask below that. The Indian Academy of Pediatrics mentions that mask can be used about 2 years, 2 to 12 years, but an adult should supervise it. Less than 2 years is not recommended, because the mask can have a problem with difficulty in breathing and other things. So we go by that. Between 2 years and 12 years, use a mask under supervision, and above 12 years, everybody should be asked to use a mask. Hand hygiene, we're talking a lot, we know a lot. Hand hygiene, hand hygiene, and hand hygiene. There's nothing to beat that. And emphasis on not delaying routine vaccination or seeking medical care if sick. If the patient is sick, don't wait. Ask to contact a medical personnel. And even the COVID vaccines, they say, see that the family members are all vaccinated with the COVID vaccine, so that the chance of getting it for the child is less. Because the children below 16 years, maybe 18 years, the COVID vaccine is not yet approved. So get the adults vaccinated. Not that the adults who are vaccinated will not get the disease, or they will not be able to transmit the disease. They can still transmit the disease, but at least a large population would be away from the disease. So the children are the child getting it would be very much decreased. Now, is there a third wave? This is a question everybody is asking. What is mentioned is that there was a third wave in November, December, October, November, December. So if at all there's a third wave, what they say is that children are going to be affected the maximum. So we got to be on our vigil. We got to be careful that we got to observe all these things. Tell the parents to be careful, so that we don't go in for the third wave. And if at all the third wave comes, the children are well protected. Thank you. And let's hope that we have a beautiful sunrise in the days to come, and have a better world to come on to. Thank you.